This video is about hip replacement and specifically anterior hip replacement. The symptoms of hip arthritis are typically pain within the groin, and this can hurt with many activities like walking, running, and even sitting for long periods of time in the car. Initially, we will evaluate you with x-rays, and that will formally make the diagnosis of hip arthritis. Once that diagnosis is made, we can start with non-operative treatment. Non-operative treatment would consist of activity modifications, weight loss, use of anti-inflammatories, Tylenol, some physical therapy to work on strengthening, and a lot of times we'll even try an intra-articular cortisone injection, and all these things can be done in the office. Eventually, the hip arthritis is bad enough, a lot of these non-operative management modalities will start to wane in effectiveness and are not going to work as well, and that's when we then begin to consider surgical treatment options. Really, your only surgical option for hip arthritis is with a hip replacement. There's, in general, two specific approaches that surgeons will use to do a hip replacement. You can do a posterior approach where the incision is made over the buttock and the hip is approached from the back of the hip. And then an alternative approach would be what we call an anterior hip replacement, or a direct anterior hip replacement, in which the incision's made on the front of the hip and the surgeon can access the hip from the top down. There's different advantages to both these options, and I will actually use both of these approaches in different circumstances, but my overall preference in the correct patient would be for the direct anterior hip replacement. In my opinion, the big advantage of a direct anterior hip replacement is during surgery, the patient is laying on their back, which is a very easy position for anesthesia, and it's a very easy position to place a patient. Typically, people have more tissue on the back of their hip than on the front, so it's typically a shorter distance to get down to the hip when you enter from the front. I think the number one advantage of doing a direct anterior hip replacement is you can do the whole surgery under x-ray. So the cup can be placed under x-ray and the perfect position can be confirmed using x-ray, and then likewise the stem can be placed and the x-ray can be used to confirm perfect sizing of the stem, and then also equal leg lengths that match your other side. And this is done much more accurately when compared to a posterior approach. So in general, with hip replacement, you will come to the hospital that day. Anesthesiologists will typically perform what we call spinal anesthesia, which is an injection into the back. That will completely make your legs numb and paralyze the legs to allow us to undergo the surgery. Now, you'll be completely sedated, so you won't remember anything and you won't feel anything from the spinal anesthesia. The surgery itself typically lasts anywhere from 45 to about 60 minutes. After this is performed, you will, as soon as the block wears off, you'll get into the hospital room and you will immediately work with physical therapy. Therapy will get you up and get you walking that very same day, walking the hallways, and we'll make sure that you're comfortable, make sure that you're using the bathroom, make sure that all of the pain is controlled in that first day. Most patients choose to stay one night, and insurance does pay for a one-night stay. And likewise, you'll wake up early the next morning and again work with therapy and make sure that you're walking a significant amount of distance in the hallway, and make sure that you're ready to go home that very next day in a safe manner. Everybody's discharged from the hospital usually before noon the next day. You'll go home, and the physical therapist and a home health nurse will actually come to your house for about 4 weeks. So all of your therapy will be done in your house, in the comfort of your house, for those first 4 weeks. I recommend not leaving the house really to do anything in those first 3 weeks specifically, just to allow all the skin and soft tissue to heal and make sure you don't put yourself in a dangerous position where you may fall. At 3 weeks, you'll come to my office and we'll make sure the incision is healed. I use what we call a subcuticular closure, which is all the stitches are inside the skin, so no stitches need to come out. At that point, most patients are ready to wean off the walker or have already weaned off the walker and are ready to transition to a cane. My ultimate goal is for you to be walking with no assisted device by 6 weeks post-op, and almost every patient is ready, usually by 4 or 5 weeks, to be walking with no assisted device. I will typically follow up with you again at 9 weeks post-op And by that time, I would say most patients are doing very well, are typically pain-free, and are typically walking with no assisted device, and are usually ready to return to whatever job they were previously doing, really regardless of how high demand that job is. Often get a question about returning to work. What I tell patients is if you do a desk job, I would recommend taking at least 3 weeks off of work before going back to work. If you do more of a mid-level activity type of job, I would probably recommend taking at least 6 weeks off. And if you are working a very high demand job like construction, police officer, fireman, or something where you're lifting a lot of weight on your feet quite a bit, I'd recommend taking between 9 and 12 weeks off before going back to work. Overall, I will follow up with patients at 1 year post-op to make sure everything's going well, and if patients are doing well at that point, then they will just follow up with me on an as-needed basis.